about 4 major factors which reduce hand hygiene effectiveness. First and foremost, we're going to talk about the jewelry. Right? Most of us love putting on the jewelry when we are doing care activities, but what we know is, and what has been proved, is that rings and bracelets actually increase the microbial count on the hands, and the rings also increase the risk of torn or pierced gloves. So there's a lot of studies that have been done, and the recommendation is that we should not be putting on jewelry during patient care activities. And in those instances where you have a bracelet which cannot be removed due to religious reasons, we recommend that you may push it up as high as possible before you perform your hand hygiene. The second factor that we're talking about, I'm going to touch on, is the skin integrity, because the condition of the hands can influence the effectiveness of hand hygiene, and skin care is essential for the best infection control practices. So if you have skin cracks, if you have dermatitis or cuts, this can trap bacteria in your skin and hence increase the risk of transmission. Therefore, we encourage you to inspect your hands for cuts and open sores, and if you have cuts, you have to then cover them with a waterproof dressing. And then you can also use, in cases where you are using the hand washing soap, which can leave the skin very dry, you can use barrier creams and lotion so that your skin remains healthy and hydrated. The third factor, which is really a cause of concern, is the nails. We have here where I'm going to talk about the artificial nails, I'm going to talk about the nail length, and I'm also going to touch briefly about the nail polish. So the artificial nails and the nail extenders, this is very common amongst women. They increase the viral load of bacteria up to 9 times compared with the other bacteria that is found on the hand. So basically, we do not recommend this in healthcare practice. And then the size of the length of your nails, they should be a maximum of 1/4 inch long, and they should not extend past the end of the finger, because most microbes on the hands come from underneath your fingernails. And what we know is, in addition to that, long nails are very hard to clean, and they may lead to more frequent puncture in gloves from the thumb or from the forefinger. Then the nail polish, this one should be freshly applied. That is, if you're not in the hospital settings. And studies have shown basically that chipped nail polish and polish that is older than 4 days can actually harbor microorganisms. So when we are now polishing our nails, and when it comes to hand hygiene issues, we have to put into perspective these factors. And the fourth factor is the water temperature in the products. Remember, the products, I just spoke briefly about them at the start of the session, where I said that it should be skin-friendly and should be acceptable by the users. So we know that warm water removes less protective oils than hot water, and hot water in most cases increases the likelihood of skin damage. So to prevent contamination, these products should be dispensed in a disposable pump container that is not topped up, and you should ensure that you use an adequate amount of soap so that it can dissolve the fatty materials and the oils from the hand. And then we talk about the 5 moments for hand hygiene. I know most healthcare workers, we say that we are now so much used to these, we have memorized them, we know them, but what is important is when the timing of the hand hygiene moment. For example, most of the problems come with moment 2, which is before clean or aseptic procedure, whereby there is so much confusion on when the hand hygiene action should actually be performed. And then the other issue that we should know is in healthcare facilities as we do patient care activities is the difference between the patient zone and the healthcare area. Because in the patient zone, that is where all the 5 moments of hand hygiene apply. So the patient zone is basically made up of the patient, or it consists of the patient and the surfaces and items that are temporarily and exclusively dedicated to him or her during the time of hospitalization. It has 2 critical sites, which are the clean site and the body fluid site. And as we say, the patient flora predominantly contaminates this zone. And then the healthcare area is what is outside the patient zone, and it contains all surfaces in the healthcare setting outside patient zone or of patient X. It includes other patients and their patient zones and the wider healthcare facility environment. And the healthcare area is characterized by the presence of various and numerous microbial species, including multi-resistant germs. So these definitions actually come into play when it comes to understanding the 5 moments, because it defines where each moment is supposed to happen. And then also the definition of point of care, because as we go around, we see alcohol-based hand sanitizers, or we see water stations in corridors, and then they are said to be at point of care. Point of care is defined as a place where 3 elements occur together. That is the patient, the healthcare worker, and care or treatment involving the patient. That is within the patient zone. So the concept of point of care embraces the need to perform hand hygiene at the recommended moments exactly where delivery takes place. So this requires a hand hygiene product, for example, an alcohol-based hand rub, to be easily accessible, that is within arm's reach, where the patient care or the treatment is taking place. So the point of care products should be accessible without the healthcare worker having to leave the patient zone. And then the other important component that we talk about is the hand rub technique. And I'm going to talk more about it in the next coming slides, because it's not just a matter of you rubbing your hands for 20 minutes or rubbing them for a minute, but it has to do with the technique. So you have to teach the healthcare workers and communities about the proper hand rubbing technique or the proper hand washing technique, as evidenced in these slides. And so what we are doing, people have been, our healthcare workers have been given so much information about hand hygiene, about the spread of our transmission mechanisms of coronavirus, but now we have to zero in on the behavior change strategies, as we have to ask ourselves, like, with all this information that we have, why is it that our behaviors are not changing? So whilst we roll out these hand hygiene trainings, we use some of the behavior change strategies, which I'm going to talk about next. One is the use of the check light machine. So here, what we'll be doing is we contaminate the healthcare workers' hands with a rub or some gel, which mimics viruses. And then after some time, we ask the healthcare worker to actually pass their hands through a UV light. And when what happens is, when the hands are contaminated, the hands will be glowing under the UV light. And then we also have another form of technology, and which is called the shore wash technology. Please note that the check light and the shore wash, what private organizations for patient safety have also contributed in terms of hand hygiene teaching, and also making sure that we apply behavior change strategies. So the shore wash machine is displayed in that picture that you are seeing. It's a machine which can be turned into a phone app, And its sole purpose is to actually teach healthcare workers, patients, or the community the proper step-by-step technique of how you should wash your hands. So it has various phases. It starts from a beginner's phase, and it times you on the techniques. It takes you step by steps, and it shows you how you should improve the technique. And not only does it stop there, it also has a quiz, a question and answer segment, which ensures that whilst you are practicing your hand hygiene techniques, you can also get a bit of theoretical knowledge about germs and about the transmission with regards to hands. So this is also available in a phone app, and which you can use offline when you are at home or during tea break or a health break, and you practice and hygiene techniques. So those are some of the things that we use in the training as behavior change strategies. We also review the healthcare associated infection audits, like what the rate of your healthcare associated infections before a hand hygiene training was rolled out. And then we come and mentor you over some time, and then we compare the rates before interventions and after interventions. And then what has worked also in changing behaviors is the use of hand hygiene awareness videos. For example, the point of care videos, those that have been part of the hand hygiene trainings. We know ICANN has this video that we term the blue video, which shows a healthcare worker's day from the start of a shift up to the time she gets home, and what she picks up at the germs at work, and how she distributes them during care activities. And then the other behavior change strategy that we have applied, which we have seen working, is the refresher trainings. So after the 3-day training that we roll out, we follow it up online. After every fortnight, we have about an hour or two where people then now share their experiences and their best practices on what is now happening in their facilities. And Jacob is going to talk more about it in the next session. And then here, when it comes to the proper hand hygiene technique, remember I mentioned the use of a check light machine. And we know about this diagram, which shows the frequently missed or forgotten areas in the hand. The first one there on the left being the palm of your hand, and the gray areas showing the areas that are most of the times forgotten. And the picture shows that those areas, how they look like under the UV light. So this picture was taken in one of our trainings as we were demonstrating how heavily contaminated the hands can be. So with that being said, we want to find out what has been happening in Africa in terms of hand hygiene. So what we have seen is there's intensified hand hygiene trainings amongst healthcare workers. And the good bit is also that the countries have built capacity to manufacture alcohol-based hand rub using WHO formulations. So most countries in Africa, what they've done through their universities, they have started locally producing the alcohol-based hand rub and donating it to the hospitals, and also sending some to the supermarkets and pharmacies for sale. But however, what is worrying is that despite the availability and increased uptake of alcohol-based hand rub in care activity, there is still no documented evidence to suggest an increase in hand hygiene compliance rates amongst healthcare workers. So this would be one interesting area of research to find out whether healthcare worker hand hygiene compliance actually got better during this pandemic. And there's also confusion amongst healthcare workers on when soap is supposed to be used or when alcohol-based hand rub is supposed to be used. We've seen in certain instances whereby you find a healthcare worker first washing their hands with soap and water, and then immediately follow with applying an alcohol-based hand rub. That is actually a wrong practice, and it is not recommended. So despite all those positive efforts that have been put in place, we still have challenges, and we still have quite a long way to go. And most of the challenges that come out is, first and foremost, is the proper understanding of the WHO 5 moments for hand hygiene. Because if you do not understand them, then that is when you'll be having missed opportunities for hand hygiene. And there's also confusion about the understanding what constitutes a patient zone and what is the healthcare area. Because remember, earlier on, I highlighted the need for a point of care happening in the patient zone. And then there's also the confusion or the misunderstanding of the definition of point of care. The other challenge that we have is adhering to the proper hand hygiene technique so that your hand can be properly cleansed. And a very, very common practice, which is applying alcohol-based hand rub on top of the gloves. And then the behavior change strategies, as we said, what we know is what we do not practice. And then we're fortunate enough to have studies that have been done to back up, especially the practices of decontaminating and reprocessing gloves, as this were done by various people, and WHO actually issued out the recommendations that any practice to do with glove washing, decontaminating, or reprocessing is not recommended, as it may damage the material integrity and jeopardize the glove's protection function. And though evidence exists that cleansing the gloves using an alcohol-based hand rub solution is effective, this study also shows increasing contamination rates of hands only after 9 or 10 cycles of cleansing. Hence, we say that this practice is not recommended. And then now we move on to the community and hand hygiene. Just remember, one of our strategies, which is key in combating the spread of COVID-19 in the community, is hand hygiene. So what we have seen is there's strengthened hand hygiene practices in the community, whereby even the communities that have no running water, they now use alternative systems. And from the pictures, you can see the use of PP taps, or we also have our own non-touch techniques in Africa, whereby you can have a drum and you have different pedals, one where you press with your foot and it dispenses soap, and on the other side, if you press, you will then get to have water. And we've also, during awareness, we are training on good hand hygiene techniques so that they follow the proper technique when they are cleaning their hands. But however, we still have some problems with glove use in the community, because with the advent of COVID-19, initially the community was seen in supermarkets with gloved hands, and with increased awareness, and we've seen that this practice is becoming less and less. And what has been proven, as we know, is that coronavirus can also survive in surgical gloves for 8 hours. So glove use in the community, it is not recommended, and this should be used in the hospital settings. And then the promotion messages that we use in the community is that we encourage family members and visitors to do hand hygiene at home, and they consider the use of water and soap, or if they can afford the use of an alcohol-based hand rub, and we teach them the moments when hand hygiene should be done. That is before and after cooking of food, before and after eating, after cleaning, after handling of waste, and after using the toilet as some of the examples. And for the challenges that we have in the communities, there is water shedding, whereby there are some communities that can even go for more than 7 days without accessing water. So they end up taking water from unprotected sources to use. And then there's the issue of the alcohol-based hand rub sustainability issues. And I gave some examples of how much pocket-sized sanitizer costs in US dollars in the various countries. For example, 100 ml pocket sanitizer costs about between $2 and $3 in Cameroon. And in Sierra Leone, it costs about $2.80. In Nigeria, it's $2. In Zimbabwe, it ranges between $3 and $5. And basically, if you are using about 5 meals per every hand hygiene action, that means that after 20 actions, you will not be having a sanitizer. And if you are using it in your family and you are a family of 6 people or so, how much will you require in a month's supply? And then we also have problems with some hand disinfection products that are being used in the supermarkets, causing skin reaction. Others are too dry, and some just don't have a name. You don't even know what is being applied into your hands, and people are even afraid to use those products. And then our other challenge in the community is in as much as the communities have embraced the need of using alcohol-based hand rub, you find that in some supermarkets, there can be shortages. Some are hoarding, and some it's you are told that it's only 1 per customer and you'll be sold a 100 ml bottle. And then also, as some challenges in the community, we have unverified messages from social media platforms. I just took a snapshot of what was circulating in a certain WhatsApp group where somebody was saying, for you to make up your own sanitizer, you can take 1 part of glycerin with 3 units of methylated spirit, and you shake the mixture and pack in whatever dispensing container that you have, and you can carry it on in your bag. And we all know that that is a wrong practice, and that should not be done. Then with that being said, there are other hand hygiene initiatives that are happening to promote hand hygiene, both in healthcare facilities and in the community. We have the Hand Hygiene for All, which is a whole of society approach to achieving universal hand hygiene and stopping the spread of COVID-19. And this is an initiative from WHO and UNICEF, whereby they are implementing the WHO global recommendations on hand hygiene to prevent and control COVID-19 pandemic by working to ensure lasting infrastructure and behavior. So it builds upon and supports existing programs such as the WHO Save Lives, Clean Your Hands Global Campaign, and the Wash in Healthcare Facility initiatives. And the global initiative has 3 stages whereby we're responding to the immediate pandemic, rebuilding the infrastructure, and reimagining a hand hygiene being part and parcel of what happens in the society. And hence the call is for everyone to get involved through advocating and making sure that the right messages reach the people. You include hand hygiene in your progress updates about access, behavior, and case study reports. You commit to increasing and streamlining hand hygiene within your organization and programs, and you share joint statements or public brief and proper key messages on social media platforms. Well, basically, the lessons that we have learned during this time in terms of hand hygiene is that the training workshops on their own are not sufficient to achieve good IPC practice. Hence, we need to emphasize on behavior change strategies, and also that in as much as we support partners coming in to assist, there is need for coordination so that we do not have mixed messages and confusion in practices. So for the recommendations, what we need to do is to scale up the trainings, plus with mentorship for the hand hygiene observers and monitors. And then we'll put more emphasis on understanding hand hygiene, especially with the 5 moments, the hand rubbing technique, and the hand washing technique. And finally, what I would want to leave as today's message is, if coronavirus looked like that spider in your hand, would you change your behavior towards hand hygiene? Thank you. Over to you, Susan.
Thank you so much, Lizzie, for an interesting presentation. Now we go over to Mr. Jacob. Kwani Jacob Gopte works with the Cameroon Baptist Convention Health Services. He is a board member of the Infection Control African Network, ICANN. He is a holder of Bachelor of Science degree in Nursing from the University of Hull and Masters of Public Health from the University of Rompton, and had 20 years experience in IPC. He has initiated, implemented several IPC projects in Cameroon. Welcome, Mr. Kwan Gopte. Please start sharing the screen from your side.
Okay, thank you, Susie, sorry. Can everyone hear me?
Yes, we can hear you.
Thank you. And if you see my screen, please just signal so that I can continue.
Yes, we can also see your screen.
Oh, good. Thank you. I want to welcome everyone. Also want to thank Lizzie for the excellent presentation.
Excuse me, I cannot see the screen.
Is everyone seeing the screen?
No, I'm not. I don't see it.
Okay, let me stop and come back again, maybe. Okay, can you see now?
Yes, I can. Thank you.
Oh, great. Thank you. I will be discussing on the experience of Cameroon in improving hand hygiene. And we are using this as an example of facilities that have limited water. I'm going to be building on the foundation that Lizzie has laid for all of us. The objectives are there, and we will use this outline. We will first talk about the background. Then we will have some basic concepts about wash. Then we will look at hand hygiene specifically. And then after that, now we will look at the improvement strategies, the phases and the strategies that we use. And then we will also touch a little bit on the local production within our system. And then we'll look at challenges and way forward, and then we'll come to the conclusion. I am actually working with the Cameroon Baptist Convention Health Services, which is a network of over 90 health facilities, ranging from big hospitals to small health posts spread in 9 of the 10 regions in Cameroon. We are seeing more than 1.5 million patients per year. And the facilities are very far off from the big cities like Douala and Yaoundé. I am just painting this picture so that we can understand exactly what it takes to have some of the supplies reach some of the facilities. Generally speaking, IPC wash is the foundation of quality care. And the World Health Organization actually says there can be no care without IPC wash. If you can imagine somebody conducting a delivery in a facility where there is no water, then you can really have a picture of what I'm talking about. Therefore, lack of IPC wash services compromises the ability to prevent infections in our first health facilities. And for that reason, there is usually an increase in the risk of healthcare-associated infections, maternal and neonatal mortality. IpC wash, as I said, is very, very important, and the only way to guarantee the safety and the quality of care that we offer throughout the world. And in the words of the WHO Director General, he said, IpC wash promotes human dignity and well-being. For example, if people are using a facility without a toilet, for example, then you can imagine what it would take for somebody to ease himself. For example, a female, sometimes they might not be able to visit that facility because they are not sure how well they can ease themselves when the time reaches. And the importance of IpC wash cannot really be overemphasized. It also reduces healthcare-associated infection and the maternal and newborn death. So the best way to reduce maternal and neonatal mortality is to ensure that we have basic IpC wash services. And then antibiotic resistance is also a very big problem. When we have IpC wash services, then it will reduce the need for use of antibiotics. And the fewer antibiotics we use, then the more we can prevent resistance. But unfortunately, the status of IpC wash all over the world is very, very poor. In a survey that was conducted by WHO and UNICEF in 2015, it was actually discovered that out of the facilities, more than 50,000 facilities that were assessed, 35% of them did not have water and soap for hand washing. And we mean that if people offer care and they are not able to wash their hands, they will spread the infection to themselves and to the rest of the people in that facility. And they will also carry even the infection back home and contaminate people in the community. This study was actually done in 2015, but there are more recent studies that even paint a better picture of the situation, indicating that it is even worse than the figures of 2015. In terms of water, in most facilities, you will see tanks as tall as this one on the picture, but no water. And sometimes where the water is available, it is of very, very poor quality. And even if you wash your hands and the water is not of good quality, then you will simply contaminate your hands and then you will spread the infection across to the rest of the people. And unfortunately, in most of the health facilities, the treatment systems are not available. The WHO has actually put a target for IpC wash. And according to that target, by 2020, the target was that 100% of all the health facilities should have already conducted baseline IpC wash. And by 2022, at least 60% of all healthcare facilities would have had basic IpC wash services. I have not seen the recent report, but it is very obvious that the target has not been met in many facilities and in many countries. If you look at the situation in Cameroon, you find people waiting by the taps with containers, sometimes as long as 2 hours or even more, because there is no water. I know this is not just a situation of Cameroon. I have also seen this kind of picture in several countries where people need to get up maybe as early as 1 a.m. and in order to have water, because they have to wait for a very long time before they are able to get at least 20 liters of water. So now, if this is the situation in the community, where sometimes they don't need as much water as we need in the hospital, then you can imagine how bad the situation can be in the hospital. So there is no health facility that can function effectively without water. And in fact, I really want to say that if there is a health facility that does not have water, we really cannot call it a health facility per se. Hand hygiene, as Lizzie said, is very, very important. and it is the most important strategy to prevent infections, especially in the healthcare facility. So when we do proper hand hygiene, we improve the quality of care because the care that we provide is going to be safe. Patient will not be contaminated. And in so doing, we will reduce the risk of healthcare associated infection and the need for antibiotics, as I said earlier. There are different hand hygiene systems, but the thing I want to highlight here is that we should not only depend on the standard systems. I mean, wherever we don't have the standard system, there is always a way out. You can design your own locally, but the most important thing is it should be able to deliver water in a manner that is free of contamination. So these are some of the systems that we have seen around Cameroon and that we are using within our healthcare services. And I want to highlight more on the one to my right, which is a bucket on a stand, 2-level stand. One above, it could be 5 liters or more as the case may be, and then one below that can be used as a receiver. Recently, we have seen more improved techniques, which you are going to see in subsequent slides. And then if you are not using water for hand washing, you may be using a hand rub, and the delivery system for hand rubs can also differ from one facility to another. I will be talking about our improvement in Cameroon within our network. Generally, there were 5 drivers, 5 things that really encouraged us or that facilitated the improvement process. And the first thing was commitment of the leadership in place to facilitate the improvement, as well as the IpC staff and the rest of the staff within our network. And then the second thing is that there was already a general awareness to improve. There was, before we started the infection prevention program, there was an assessment that was done in 2000 in which they discovered that the quality of care was not up to standard. And therefore, the recommendations, the people who did the assessment recommended that there was need to improve. And one of the strategies was to start an IpC wash program. And effectively, that IpC wash program was started in 2002. And I happened to be the pioneer IpC nurse at that time. Then we also have a good management system where there is coordination at the central level in terms of supplies and finances and the administrative issues and so on and so forth. So if you have something that you want to do and the head approves it and sends out a letter, then it is usually implemented very effectively. And then the last and the very good thing is creativity and innovation. A lot of things we want to do, we will not have the standard supplies. But if we are not creative, if we cannot innovate, then it will be very, very difficult. Then the improvement actually, we'll be looking at it in 3 phases. And the first phase, I titled it initiation phase, which is from 2002 to 2012. At the initiation phase, the focus here was to building the structures and the systems of improvement. And the first thing we did was to begin local hand rub production in 1 facility in 2002, and then which was later piloted in 4 facilities in 2012, from January to April 2012. And then we scaled up to 37 facilities from December. And presently, we are using hand rub across all the facilities in the system. As I mentioned about infection prevention wash program being a driver, we actually started infection prevention wash program in 2002, where 2 IpC nurses were appointed, and I was one of them. And we started looking at the problems using guidelines from different countries. And when we started, we discovered that there was an outbreak, there had been an outbreak of neonatal sepsis in the obstetric unit affecting several babies. We actually did a culture of the sepsis as well as knee abscess, and we discovered that there was staphylococcus and Pseudomonas growth. And then when we tried to investigate the unit where the babies were being taken care of, we discovered that there were some risk practices For example, they were bedding babies in one small room, and then they will use petroleum jelly to apply on all the baby from a common container. They will use a common soap, then use a common container of petroleum jelly to apply on the babies. And that same jelly, the staff used to apply on their hands to prevent it from drying, as well as on their lips. And so when we culture that petroleum jelly, we have the same growth as those from the patient. So we decided now to remove those containers, and then we introduce individual items, personal items for every baby, including soap, including diaper, including bath basin, including the petroleum jelly. Each mother had to have their own. And then when the midwife, they watch the baby, they will give to the mother, and the mother will apply the petroleum jelly at bedside. And we also discourage them from sharing with their neighbors. So now when we also evaluated the unit, we discovered that there was only one hand hygiene station, which was reserved only for the doctors during rounds, and the rest of the staff were not allowed to use it. So when we evaluated this, we discovered that it was difficult to install the regular sinks, and therefore the only option we had was to multiply the portable hand hygiene stations. And then we also started producing hand rub in the hospital at that time. And therefore, when we were also tracking the incidence of the neonatal sepsis, and we discovered that they dropped significantly as hand hygiene improved. So from this experience now, we decided to share the knowledge to the rest of the facilities within the network. Then all our improvement strategies were rooted on the WHO hand hygiene framework, which is a multimodal strategy of approaching any change process with focus on the behavioral change. And the emphasis was on my 5 moments, which Lizzie mentioned earlier. Then we also were very intentional and purposeful, and we're also systematic. Any improvement process, you must be very, very intentional. It doesn't come by accident. And before you begin, you must really assess what do you want to improve and how do you want to improve. What are the possible challenges you might meet? And if you don't know the challenges, sometimes when they do come, sometimes you may be overtaken. And one of the things that we must always take note is that every change process is slow, and you must always have resistance, whether you like it or not. So you must be prepared how to face resistance when it do come. Then the next thing is that the change must be systematic. For our case, we did a baseline assessment to establish the level of the problem. And during the baseline, for each facility, the head of the facility and the key staff, they participated. And when we did the baseline, we presented the results so that everybody knows at exactly what level their performance was. And then when we did the baseline now, we followed now by implementation. And during the implementation, we went around all the facilities, and the heads of the facilities, they will sign a commitment to improve hand hygiene in their facilities. And the signing of the commitment was done publicly. They will read the commitment to the hearing of all the staff, and then the head of the facilities will sign, and then we will demonstrate hand rub application on the spot. And then we also follow up with the follow-up assessment 5 months later to determine the level of improvement. Then any improvement should always target the system and not individuals. Change, actually, once you change the system, the individuals will change. But if you don't change the system, it is very difficult to implement any change. Then the next strategy we also used was public sensitization and demonstrations, and then training, several training. We did several trainings centrally and at facility levels. Okay, for commitment, the commitment must be written. When it is written, at least you can always make a reference to it. A verbal commitment, usually it is good, but it is not good enough. For our case, we actually caused the director of CBC Health Services, who is the CEO of our system, to sign a commitment publicly, as you can see on the picture. And this was followed by similar commitments in all the health facilities. And when we went to the health facility, the CMO, the administrator, and the supervisor of nursing services, they signed on behalf of all the staff of the facility. And as I said earlier, all the commitments were done publicly in front of all the staff. And then any meaningful improvement process should also involve leaders. If the leaders don't buy into that improvement, it is difficult to improve. So once you convene the leaders are going to convene the rest of the people under them. For our case, when we discussed with the Director of Health Services and he approved, and then he signed a commitment, he issued now a circular letter to all the facility heads, instructing them to sign the commitment as he has done, and also instructing them to ensure that hand rub is available at the point of care. Now, with this instruction, now it was easy for us to get the other staff of the rest of the facilities to buy into the improvement process. Then phase 2, I titled phase 2 as implementation phase, which is from 2017 to 2020. As I said earlier, we did a baseline assessment in May. And when we did the assessment, we disseminated the results to all the facilities. And at that time, we assessed 34 facilities. And out of the 34 facilities, only 31 of them were able to be at the basic level. The basic level means that the hand hygiene performance is between 126 to 250 over 500, because we're using the WHO framework, and that framework has a checklist that you have a series of indicators, and they indicate there are 27 of them in number, and you grade them on 500. And then any facility that's scored between 376 to 500, we classify it as advanced level. The facility that's scored between 126 to 375, you classify it as basic. And then the facility that's scored between 125 and below, we classify it as inadequate. So when we did the baseline assessment, 3 facilities were inadequate, and none of them was at advanced level. So mean that 31 were at basic level. And then we did a series of trainings, public promotions and sensitization, as you can see on the picture. And then we repeated the assessment in October, 5 months later. And at that time, all the facilities moved to basic and intermediate. All the facilities moved to basic and intermediate. Let me make a small correction, please. Intermediate is actually between 251 to 375. Then the one that is 126 to 254 is basic. Sorry, I missed that point at the beginning. So now, what were we actually looking for? One of the key indicators that we used was to keep track of the number of hand rub points that were at the corridors and at the doors and at the point of care. And so we continue to follow up from December 2017 up to 2020. And then these are some of the training sessions that we have both centrally and at the facility level. Now, at baseline, we had 160 hand rub points. Then when we did the follow-up assessment, they had increased to 300. That is more than 100% improvement. Then when we also did a follow-up assessment in December, they have improved to 700. And then in February 2018, they have increased to 1,500. We have not done a recent assessment, but I know that especially after the outbreak of COVID-19, a lot of hand rub points were multiplied in the different facilities. I am sure we'll be moving to more than 3,000 now. Then phase 3, I call it the COVID-19 period, which is a period characterized by a lot of technological explosion. not only in Cameroon, but even in different countries. I think you will acknowledge with me that after the COVID-19, a lot of people who even did not hand washing in the past, you see in community, you will see hand rub stations and even in public buildings. So in Cameroon, we have this kind of containers that are available in most of the facilities as we went around. You see the one to my left and then to the right. These are common portable hand wash points that we found in the facilities. But what is very, very key is the one down to my right, the one that we met in one of the facilities at the entrance to the facility. Now, if you look at the hand wash system, you see how attractive it is, how good it is, and everybody who was coming into the facility was actually required to do hand washing here before they moved to the facility. Then this other one to my left, if you see this door is the gate, door to the gate, and you see hand wash a sink right at the gate. Everybody was also required to wash hands here before they enter. You see, there is hand rub. And then if you look at the middle, interestingly, even those who do not have the regular system, they introduce what they think could help. This is about hands. We also seen in the system. You see pot. Can you hear me, please? Hello?
Yes, we can hear you.
We can hear you.
Oh, thank you.
Yeah,
So these are some of the systems that we have found.
Screen. We are following President, but you are not sharing the screen. You must share the screen with according to your presentation, please.
Okay, the screen just went off. Please let me know so that I can continue. See my screen? Hello? Can you
You're
see
back.
my
You're
screen?
back. You're back, Jacob. You're back.
Oh, good. That's fine. Okay, thank you. So I was saying that these are some of the systems that we have seen COVID-19. This is just a small sample out there, both in Cameroon and in. Just talk a little bit about the hand rub production. As I said earlier, we started the hand rub production in 2003 after the outbreak of, we discovered an outbreak of neonatal sepsis in one of the maternity units. And in that unit, hand wash systems were very, very limited. So we started producing in one hospital locally. And then from 2012, we decided to scale it up in from December 2012. And then after that, now we centralized the production to one unit in order to benefit from the economy of scales, as well as the expertise of the staff, because they were already involved in producing other pharmaceutical products. The one key thing we must note here is that our production is 100% manual. It is not yet automated. And most of the raw materials are imported out of Cameroon. The production process will begin with mixing. You mix the products, and then we do filling. When we fill, we hold the products awaiting quality control results. And then when the quality control results come out positive, or no, let me say negative, not positive. When they come out indicating that the product is of good quality, then we will now go ahead to distribute them to the different facilities. And the facilities, they range from very far off to near facilities. And sometimes it might take up to a week for the hand rub to reach some of the facilities because of the distance and also because of the nature of the routes, especially in the rainy season, that is from between July and August, where due to heavy rainfall, some of the routes are very, very difficult to navigate. Then we have a series of dispensing system. We have 100 mils, which is meant for star pockets and can be used at the point of care. Then we also have 500 mils, which is meant for wall dispensers or for work surfaces. And this one, we usually mount them at the point of care by the patient's bedside, in the corridors, and the main entrance, the doors, and so on and so forth. Now, these are the standard ones that we use, but these are the ones that some staff, some facilities, because of lack of these two, have also designed. You see a small bottle, a green bottle, a green bottle hanging on a window. This bottle contains hand rub, and it is at a place where people are supposed to register patients, and then each one, including patients and visitors, are supposed to use. And then the picture to my left hand, you will also see a small white bottle hanging by the door. It also contains hand rub. So these two below are the ones that were introduced at the different facilities because they didn't have the standard containers. As I said earlier, any improvement process, you must not rely on standard supplies. Once you don't have, then you need to use your head to design what you could also use to follow up with the same thing without compromising. Now, we had a series of challenges. The first thing is that our production capacity is very low because the process is entirely manual. And so for us to produce a large quantity, sometimes it takes a longer time than if we were using standard machines. Then the delivery systems are also difficult because of bad routes and also because of distances. And then since most of the raw materials are also imported, the cost has a very serious cost implications. And then we do not have the appropriate equipment for automation, and we also have not had funding to improve the process. Notwithstanding, we are very determined to move on with what we have in order to sustain the improvement process. So what is the way forward? The way forward is to identify appropriate partners. Working together is also very, very important. Sometimes what you might have as a problem today, another person already has a solution for it. So partnership is very, very important in all improvement processes. Then you network. When we network, you also learn from one another. Probably somebody can share his own experience just like we are doing now. And then sometimes you can learn from others' experience and you can be able to improve. And then specifically for our hand rub, we are thinking that we will look for ways to automate or mechanize the process. Once we automate and mechanize the process, we will increase our production capacity, and then the cost of production will drop, and then the cost of the hand rub is also going to drop, and then we can be able to supply the internal and the external market. To conclude, we are saying that hand hygiene is very, very important. This one is a very, very key thing that we should never forget. If you miss hand hygiene, then you miss it all. There is no way you can prevent infection if you don't pay very serious attention to hand hygiene. But then we are all aware that water is limited. Water is very, very limited. But then, even though water is limited, improvement is still very necessary, and it is possible. And any improvement process, we must use a multimodal strategy, a strategy that involves a series of activities and with a greater focus on behavior change. Just like Lizzie said, it is not possible that by providing hand rub alone, hand hygiene will improve. When you provide hand rub, it has to be followed by promotional activities so that you can be able to encourage people to improve. And then you do a monitoring and evaluation so that you can see which area you still have gaps. And then the next thing you also need to consider is commitment. Whoever is involved in the improvement process, you must be committed to move on, whether the atmosphere is favorable or it is not favorable. Sometimes it is really very difficult, especially if the people that you think are going to support you are not doing so. Sometimes it makes it very frustrating. And if you cannot persevere, even under very difficult circumstances, it will be difficult to sustain that improvement. Then you must also be creative. A lot of supply that you will need will not be there, but that should not put an end to the improvement process. And then, second to the last thing I want to say, if we want to improve hand hygiene, we must consider alcohol-based hand rub. There is no way you can effectively improve hand hygiene if you don't use hand rub. It's difficult to have a sink by every patient's bedside, but it is very possible to have hand rub. And if you have to use hand rub, then you must consider local production. If you are importing, there will be a lot of challenges and it will be difficult to have it all the time. First, because of the bottleneck that you will find at the different steps. And then secondly, because the cost might be very high and you might not be able to afford. So we are saying that improvement is very, very possible. And if we want to improve, then we need to seriously consider hand rub. Thank you for your kind attention.
Thank you so much, Mr. Gopte, for an interesting presentation. Now I would like to welcome Mr. Agustin Casrodi. I hope I spelled the name correctly, from the National Infection Prevention and Control, Ministry of Health and Social Services from Namibia. Thank you. Please share your screen from your side.
Okay, thank you. Let me just see if I can share it.
Please, we are out of time. I would request Mr. Agustin if you can make your presentation shortly so that we can have a few minutes.
Yes, I'm trying to see if I can share the screen, but let me see.
Sorry, Mr. Agustin, I have your presentation. Can I share the screen from my side?
Yeah, please, because I'm trying now to get here, but looks like it's not materializing.
Okay, let me do that. Yes, please go ahead.
Okay, but I cannot see my screen from here. Can I, because can I'm trying to see if I can see now my screen, but can project my screen there?
I have projected your screen. Can you see my screen?
No, I cannot.
Mr. Casteroidi, can you just start talking and just be saying next screen? If you're using yours, she can, she's on the first screen. So when you say next screen, she'll move it. And since you'll be talking from your own computer, even if you're not seeing it.
Yeah, I'm trying not to do it from my computer unless I have to, let me see. Just give me a second, I'll try to do it now.
Mr. Castro, you don't need to share your screen. Don't try to share your screen.
No, I'm not.
Talk.
I'm not trying. I'm trying not to get the screen because now on my computer's blank. Cannot access my screen on my computer.
Oh.
Yeah. Can I maybe? What can I do now? Okay. Just a second, I'll be back. Okay, thank you. Can you hear me?
Yes, we can hear you.
Yeah, okay. Thank you. I'll try now to be a little bit faster. As I said, my name is Augustine Casterodi. I'm National Infection Control Practitioner, actually, in Ministry of Health and Social Service in the Republic of Namibia. So I've been as infection control and also health worker, also responsible for, how can I say, infection control implementation in the country. So the outline country overview and an IPC challenge, best practice, lesson learned, and gaps. Country perspective, we are 2.5 million, as you know that we are a little bit less. And then the area of the country, 824,292 square kilometer, which is equal to 318 to 261 square miles. Our official language is English. If you know that Namibia, the majority are Christian, 95% are Christian. The life expectancy in male is 61 and female 67. And the current is Namibia dollar. The country got independence 21 March 1990. So formally it was Southwest Africa. Now our official name is Republic of Namibia. Still on country perspective, the country is, when coming now to political division, there are 14 regions, and then having 34 districts. So I would say that the health care facility saves 76% of the population living within a 10-kilometer radius of health facility. So meaning that a person can walk 10 kilometers or less than that to reach a health facility in the country where they can be treated. COVID information, we know that WHO declared COVID as a public health emergency of international concern on 3rd January 2020. And now, because of that, Namibia registered her first 2 confirmed cases of COVID on 13 March 2020. So unfortunately, we could not celebrate even our independence, which was to be 21 on 21st March. So by 13 is now before yesterday, it was yesterday, the cumulative cases are standing now at 12,000. And between 1 August to 13 October, a total of 9,776 cases were reported, which represented 1% of the total confirmed cases. As we know now, those cases came also outside. We had 62 of the cases were travel related. That's how we got our first case, because people who came in the country brought imported the virus. Information, COVID information, number of healthcare workers. Now we are talking about our health workers, those who are nurses, doctors. 478 were infected, and then unfortunately, we lost 2 of our members to do COVID-related death. And the summary as from yesterday, the statistics as of 13 October 2020, cumulative confirmed case, laboratory cases, stand at 12. And then we recorded newly 11 cases, and the recovery stand at 10,120. And active cases there, 1,751. A total of 129 deaths related to COVID, which means... Hello? Can I proceed?
Yes, please proceed.
Yeah. So 129 COVID deaths, which means 100 were COVID and also now related to COVID-29. So total of 129. Currently, active contacts now stand at 7,866. The total samples tested in the country since inception, we test 111,315. And then currently cumulative people, number of people quarantined who are in quarantine, there are 15,939. The number of quarantined people discharged stand at 14,917. Number of people in quarantine now currently we are having 1,022. If you see now the information here is that we're having the COVID information, we have seen a peak on up to 2,123, which is equal to 17.7% of the case were recorded during a week 34. If you see on that on the figure below, after a peak in the week 34, the count has seen a gradual reduction in average number of confirmed cases from 303 to 44, and AP week 41. The National Call Center continue operating for 24 hours despite having those decrease in numbers. So today, before yesterday, on 12th October, 1,115 calls were answered, including 144 alerts. So meaning that that's saying that they operate 24 hours to assess our public or community if they're having problem to call in, and then we can respond to see if we can now go and see them or just give them an advice. There's also a scenario on infection control that, sometimes we present stories, and then we need also to have something that a case study that we did as infection control to see or to share with other county what they think. 76 years old female patient from Windhoek was admitted on June 15th, 2020. This patient was swabbed on 11th August 2020, and the result came out positive for COVID-19 virus on 25th of the same month. So another test was done after that, the initial one, and came out positive for second time virus on September 25th. It came. And now this person has a comorbidity illness, type 2 diabetes mellitus, congestive cardio failure, and then ischemic cardio disease. In 2010, the person has an alcoholic level peripheral vascular disease, and then the patient continued having those conditions before even was admitted. So based on this comorbidity, there could be that this patient was having a problem. That's why now could not recover on time, and because of also, as you see now down the summary. So this patient was readmitted to the ward, same ward on 15th June 2020 with a septic left above knee stump. Left above knee, amputation was done. On May 29, 2020, the patient developed a dry gangrene on the left foot and was treated inpatient for wound debridement and a dressing. Progression delayed healing of the stomach due to poor blood supply and comorbidity illness. And patient contract hospital-acquired infection. Because of this nowadays, if you see the condition of this patient, which is now COVID, after being exposed to a confirmed patient in a shared room on June 4th, and then swabbed 7 days after and they tested positive on August 11, 2020. And the patient did not have any respiratory symptoms and was classified as mild case and was isolated for 1 month. The patient developed progressive dry gangrene on the right foot and then was due for amputation, hence reason for us a recent COVID swab. So it is now procedure here, a protocol that a patient, when patient going for theater, this patient need to be first swabbed. Unfortunately, on 5th October, this patient was found to be saturating on the room air up to 75% with hypotension, and then on the pulse rate of 111, and then HT 15.8, and was placed on oxygen with a non-rebreather mask. The condition deteriorated and the patient developed cardiopulmonary arrest and resuscitation with a chest compression and adrenaline was unsuccessful and the patient passed away. Now, and there was no travel history. This person never traveled. So the decision is now disputing, we as infection control saying, could be that this is now a COVID related or not. So that's now I'm sharing with the team here. What can you make out from there? Do you think it is a COVID related death or not? So that's now the question I'm throwing in. That's our case that we did as infection control practitioners. Now, actually, it's as the whole Africa, the head also IpC challenges. Our challenges that are the lack of the presentation by key institution department responsible for WASH on the IpC committee and meetings. As it was presented before, we saw that there was something like if there's no WASH, actually, that quality control is very difficult. So then there are also limited knowledge in the skills of IpC and context of COVID-19, particularly in sub-national level. So meaning from national level down to the level district and the regional, that was difficult because it's a new disease, nobody knew it. Even explain and people, they could not understand. And then we had also in antiquated PPE and the IpC commodity in the regions to keep up with the place of utilization. It was very difficult from beginning because we used to have a PPE that we used for COVID, for Ebola and Crimean Congo fever. It was limited, so it was very difficult for us not to have. There are also misunderstanding of guidelines on requirement to accept persons in a quarantine facility with a special clinical condition. Should we all of them be isolated or not? Because that's very difficult. Now we have to come to say as infection control and case management, we need to make a decision on the limited isolation facility. Obviously, we never had something like that. It's the first time that it came. It's very difficult for us now to, where can we put the patient? A school or a hospital, it was very difficult for us. And the IpC challenge multiple responsibility assigned to IpC focal person. We're having all those hospital and the counseling clinic. When the IpC focal person, they are assigned, but now they are tasked with many tasks that they could not even fulfill their work. The normal chain supply was erupted. We used to get it, but the country, the border was closed. There was no wind, there was no flight coming, now whatever. So it was very difficult. The new export regulation in many supplied countries of origin, additional requirements were required, such as registration, number, VAT, number of syringe, number of tax identification, and then of consignment of the goods. So it was very difficult for us to cope with that one. So despite all those challenges, we did something now, which if you see our case are becoming less, there's something that we did also, best practices. Meeting halls were converted in isolation facilities, ablution, doffing, as well as nursing station were added. So because we didn't have other, because we didn't have another alternative, so those halls we just decided to convert them in isolation so that the patient could be admitted. The county partnered with the UNICEF to assist and facilitate delivery with the supplies, because there was the only way that we could do, because UNICEF, they have access outside. UNICEF provided an update on of any material available and lead times, and the IpC team, as a part of the national response monitor usage, they monitor usage of PPE at facility level. And so what happened that we had a distribution, local distribution of PPE, how it would go in the country, and also we have to monitor from national level and from health facilities. So also there was something that we needed, actually collaboration, strengthen collaboration with the other directories like health technology infrastructure management to ensure that adequate construction of facilities were facilitated. So infection control, they designed the plans actually, and then it gave to those our stakeholders to build now, but we are the one who supervised how it was. We make sure that they didn't deviate from original plan. This contributed to reduction of transmission of healthcare associated infections. So meaning that because infection control, they knew this type of facilities and ventilation wise and all those that ablution system it was. So it made that our most cases that were admitted, it became, the transmission became lesser and lesser every day. So we still will enhance safety of staff, patient, visitors. We developed a SOP to guide those people who could come in the facility. And also enhance ability of the healthcare facility to respond to an outbreak. So training was offered online and face-to-face. Reduce the risk of the healthcare system, possibility of amplifying the outbreak, and then reduce the transmission to public community. So social distancing was advocating, and also because of the good spacing in the road infrastructure, it made easy that the community could comply with SOP. There was also a strategy of availing isolation beds in 30 district hospitals and 5 referral hospitals. So the construction dedicated isolation unity and repurposing available government infrastructure for isolation facilities. So this one we did in the country, but if you see now, we built so over almost 50 isolation within a shorter period when we started. I will share the picture later if I'll be able. So what we learn now to prevent that we have adopted additional guidance documents on various aspects of our IpC in response to evolving nature of the pandemic, as well as national state of emergency, including the following: management of human remains of a person who dies of COVID-19, IpC in the context of COVID in workplace, correctional service, and aviation industry, standard for making and purchasing of masks for national standard institution and training institution to support and quality control testing. So here we did, because from beginning everybody just came with their sanitizers, they want to sell masks, and then we say no, there must be some regulation, we need to validate those items coming. So infection control, they came, and then we did, our team, we did SOP, and then we gave to management, it was approved. So that made us our work more easier. We know a workplace that when from beginning when there was a person who was positive, people
sorry, Mr. Augustine, we've run out of time. Kindly round up your presentation.
Okay, thank you very much. What I'll say is that I have to thank now the facilitators that gave us now some places now for Namibia to be presented, our experience with that. We look forward to see that more support to come our way to assist us, because we need more IpC in the country. practitioners and also to assist us, because COVID is not yet to defeat the spread of COVID. Thank you.
Thank you all. Thank you so much for your presentation, and thank you to all the panelists who have presented. We apologize for we have used more of your time, and we apologize also that we cannot take the Q&A today. We would encourage you to post all the questions in our Telegram community of practice group, and our experts and some of the panelists will assist in answering some of the questions that were unable to be answered today. I would like to wish all of you a nice day and stay safe. Thank you. Bye.